Okay, let's go on to our next one. Dr. Landau, whom you'll hear from next, is from Memorial Sloan Kettering in New York City and hosts our meetings at that hospital. Dr. Landau is at most of our New York meetings. Many of you are familiar with her. And she was about to be our guest at another meeting when the COVID virus hit. So let's sit back and relax and listen to Dr. Heather Landau.
Muriel, thank you so much for inviting me here today. I think this is an amazing effort to extend support to our patients nationally. Today I'm going to speak to you about light chain amyloidosis treatment in 2020 and what is hopeful for the future moving forward. So I'm going to start by talking about the pathophysiology and the goals of treatment. As you just heard, AL amyloidosis is a plasma cell disorder starting from bone marrow plasma cells that produce immunoglobulins, and the heavy chain is designated as IgG, IgA, and IgM, and the light chain part of the immunoglobulin is designated as kappa or lambda. And normally, all people have a mix of both kappa and lambda immunoglobulins, but when the bone marrow plasma cells are pathologic, they can make too many of one kind. So then the immunoglobulin can be produced in larger quantities, and the free light chain, either the kappa or lambda, can dominate. And when the kappa or lambda circulates independently, we call that the free light chain. And it's these entities, the free light chains, that clump together and misfold and form these amyloid fibrils. And amyloid fibrils ultimately deposit in organ systems and cause organ disruption and function. The most common organs that are affected include the heart, the kidneys, the liver, the GI tract, soft tissues such as the tongue, and the peripheral and autonomic nervous system. Most of our treatments are directed against the bone marrow plasma cells, and in an effort to shut off the factory producing the pathologic light chains and reduce the production of these amyloid fibrils. But we'll also talk about new treatments that are aimed at removing amyloid fibrils and helping to aid organ recovery. So hematologic response is based on the serum free light chain assay in the blood, and response assessment is crucial for monitoring treatment efficacy, identifying relapsed or refractory cases, and for cross-trial comparison of therapeutics. So Muriel nicely has designed this biomarker to measure this biomarker chart to measure disease and organ response. And I just wanted to take a little bit of time to explain how this could help patients monitor their own response. And so, as I say, this the immunoglobulin is made up of both the heavy and light chain, and it's these light chains that are circulating in the blood and are measured by the serum free light chain assay. And again, either kappa or lambda in any one person is the dominant free light chain, and it's measured in the blood, and we get labs such as this serum free light chain assay, and you can see that the measurement of your lambda light chain and your kappa light chain, and we also measure the ratio. And then this DFLC number we use, that includes the involved free light chain minus the uninvolved free light chain. That's a number that you have to calculate. The M spike measures this intact immunoglobulin, and this total serum protein is on here, but a little bit less useful. And the reason why this is important is because the way that we define the response to treatment is by using these numbers. So a partial response is the 50% reduction in the baseline of the difference of the free light chain. So again, this number, the DFLC, that you calculate at your baseline compared to how it is moving forward. And if there's a 50% reduction, you achieve a partial response. If that number is below 4 milligrams per deciliter or 40 milligrams per liter, depending on what lab that you go to, that's called a VGPR. And a complete response is designated as a normal capital lambda ratio, which is something that is reported, and no evidence of the M spike by immunofixation. And this is important because the response to treatment really predicts outcomes. And we see here, this is a proportion of survival over time, and patients who have the best responses, meaning a complete hematologic response, live longer than patients who obviously have no response. And again, because patients with a complete response or a very good partial response do best, this is our goal of therapy. I would have to say that our criteria is imperfect and changing, such that we're learning that the reduction of the involved free light chain and to a level that may even be lower than a VGPR is probably, our hematologic response criteria is changing, such that we're learning that maximal reduction of the involved free light chain predicts better outcomes. And here I show the cardiac biomarker staging and response assessment that Muriel has provided for you. And we measure cardiac involvement by these biomarkers, troponin T or troponin I. In your lab, you'll probably have one of them, NT-proBNP or BNP. So both are probably not measured. And we define, again, cardiac responses. We have a staging system that predicts prognosis based on these numbers. And with one of these biomarkers elevated, you're designated as stage 2. With both elevated, you're designated as stage 3. And if neither of these are elevated, then you're designated as stage 1, and these have implications for prognosis. Similarly, when we look at response assessment, patients who have a 30% reduction in these numbers do better than patients who don't achieve and we characterize that as an organ response, whereas patients who increase, these biomarkers increase by 30% and an absolute value of 300, or in the BNP staging system by 50. These numbers predict worse prognosis if you have progression. There is also a kidney staging system and response assessment. The kidney staging system, which it depends on how much protein loss you have in 24 hours and the renal function, doesn't predict survival, but predicts kidney survival, meaning time to needing dialysis. If your protein loss is low, less than 5 grams per 24 hours, and you have preserved renal function, the likelihood of progressing to dialysis is small, whereas if you have large amount of proteinuria and a compromised renal function, the risk of needing dialysis is almost 50% at 2 years. But the good news is that if you respond to your treatment and you have a 30% decrease in protein loss based on achieving a hematologic response, the likelihood of progression to needing dialysis is reduced. So with that said, we know that we have to target the plasma cells with anti-plasma therapy to reduce the free light chains. And if we reduce the free light chains, our organs can improve, and organ responses, again, are measured by the cardiac biomarkers and proteinuria for the kidney, and an alkaline phosphatase when you have liver involved. And if you have a hematologic and an organ response, this shows a hematologic and organ response, or a hematologic response or no response. And if you have a hematologic or an organ response, our colleagues from Italy have shown us that you have a prolonged survival. So that is our goal of therapy. And so what is the therapeutic landscape? I would have to say that not a single FDA approved, there is still not a single FDA approved drug for AL amyloidosis in the year 2020, but I do think that it's going to change, and I'm very hopeful. So that being said, I want to speak about initial therapy, and this is the good news. That was the bad news, but this is the good news. The therapy, even though there is not a single approved drug, there are so many options, and I just wanted to walk you through this slide. Was courtesy of Jeff Zonder, and I'm going to talk about all of the different therapies for the remainder of this presentation. Our therapies come from different classes. The original therapies we used were alkylating agents. More recently, the proteasome inhibitors have come to the forefront. Steroids are actually anti-plasma cell therapy, and they have direct anti-plasma cell activity and are an adjunct to most of our other therapies. The IMIDs, or the immune modulating agents, include thalidomide, lenalidomide, and pomalidomide. And the newest therapies, which are very exciting and probably revolutionizing, are these antibodies, most commonly known as Daratumumab, but Ixazomib and Elotuzumab are also being studied. With that being said, we use these drugs mostly in combination. And for instance, when we combine the alkylating therapies with the proteasome inhibitors and the steroids, this is a common combination. We treat with cyclophosphamide, bortezomib, and dexamethasone. That is what we call CyBorD. Historically, melphalan and prednisone, the alkylating agents, the alkylating agent and the steroid was the mainstay of therapy because it was the first combination that gave a response rate, objective response rate of 25%. Overall survival, you see, however, was dismal at about a year, and we also learned from these initial studies that patients with cardiac involvement did less well. At the time that oral melphalan and prednisone were being studied, high-dose melphalan was established as a treatment for patients with multiple myeloma. And I just wanted to take a minute to explain what high-dose melphalan and autologous stem cell transplant, which is still a very important treatment for both multiple myeloma and light chain amyloidosis, but it's not necessarily well understood. So it's a little bit of a misnomer. So what autologous stem cell transplant really means is it's our ability to give high dose chemotherapy or radiation. So in this case, high dose melphalan can be delivered to the patient only because before the chemotherapy is given, the patient's progenitor cells or stem cells are collected and frozen, so that when we deliver this high-dose chemotherapy, we can rescue, which is active against plasma cells, but also potentially active against normal blood-forming cells. The stem cells can be reinfused to rescue patients' bone marrow. So that means that it's the high-dose chemotherapy that's actually treating the disease, and these stem cells are just rescuing the patient's bone marrow. They're not particularly effective at treating patients' amyloidosis. So in the mid-90s, a group was formed at BU to treat patients with high-dose chemotherapy, and of the initial 5 patients, 3 of them achieved a complete hematologic response, which again was unheard of prior to this, and all 5 improved their organ function and were alive at 1 year. This experience was expanded in the phase 2 setting, and ultimately over 300 patients were treated in the first publication, and the overall survival was upwards of 4 years. And we also learned that patients who got deeper responses, meaning complete hematologic response, did better than those who had less than a complete response. And again, patients who did not have cardiac involvement did better than those with cardiac involvement. We did understand from these early trials, however, that patients with cardiac involvement or renal compromise or were of older age had more toxicity from high-dose melphalan and were at higher risk, and that prompted us to design these trials of risk-adapted melphalan dosing based on age, cardiac involvement, and renal compromise, and we tailored the dosing of the melphalan based on these risk factors. We restaged patients after 3 months, and those who had a complete hematologic response, which was the goal, were observed, and those with less than a complete hematologic response were offered consolidation with novel agents. And with risk-adapted melphalan and stem cell transplant, we were able to show that we had a low risk of transplant-related mortality, meaning early death with patients who underwent transplant, and we could increase the frequency of the complete hematologic response from 25% at 3 months post-transplant to almost 50% at a year with the addition of consolidation. And the good news is that patients in our cohort lived a median of over a decade. So risk-adapted hematopoietic cell transplant is still widely used, but only a select number of patients, meaning 20 to 25% of patients are actually eligible, because we are doing better with this therapy because of refined patient selection, risk-adapted melphalan dosing, and again, post-transplant consolidation. So the majority of, patients can get transplanted, but this has evolved quite a bit, and still it's the minority of patients who are eligible. The one other thing I wanted to point out were when patients get into a complete hematologic response, the organs can improve, but the organs don't improve right away. Organ responses evolve over time, and I wanted to take time to show you this example of a patient on this axis. We're measuring the serum free light chain, and this is time. And these 2 lines indicate the normal range of the serum free light chain. And so when this particular patient was diagnosed, she had an elevated serum free light chain, and she had a transplant in in July of 2008. And unfortunately, she was part of the third of patients who did not respond to the transplant, but she received bortezomib and dexamethasone as consolidation. And you can see a rapid reduction in her serum free light chain. Because of toxicity to this treatment, namely neuropathy, we were giving this at IV back in 2008. She only received 1.5 cycles, and she has remained off of therapy since that time, now 12 years later. I show you this because what's remarkable is that she had very severe proteinuria, upwards of 20 grams in 24 hours. And you can see she achieved her hematologic response in 2008, complete hematologic response in 2008, but it wasn't until 2014 till her organ improved that she was spilling less than 1 gram of protein in 24 hours. And actually, at our most recent visit, she had no longer spilling protein. So again, we can treat the hematologic disease, but it takes time, meaning months to years, for organs to improve, and supportive care is critical in this setting for some time. In patients who are not transplant eligible, upfront bortezomib-based therapy in AL has come to the forefront. Here I list the most recent trials with bortezomib-based upfront therapy, and the responses are a little bit hard to interpret when you have cross-trial comparisons, because there's a mix of patients in each of the trial, meaning if you have stage 3 patients, 100% your response and your overall survival is going to be lower than if you are including less of the more advanced patients. But this just goes to show you that CyBorD results in a overall response rate in the 60 to 80% range. Bortezomib-based upfront therapy results in an overall response rate of 60 to 80%, and complete hematologic responses, which are 15 to 40%. But again, these are patients who are response evaluable, and it's probably in the range of about 15 to 25% in most trials. BM-Dex is bortezomib melphalan Dex, and this is a treatment that is widely used in Europe. It's similar to CyBorD. Melphalan is the alkylator of choice in Italy, and here I show the choice of upfront therapy. We would say that we are upfront risk-adapted hematopoietic cell transplant is really reserved for patients who have a low burden of disease to start, less than 10% plasma cells, less than 2 organ involvement, or Mayo stage 1 or 2 cardiac disease, because these patients do well with this treatment and won't require additional therapy if they achieve a complete hematologic response with a transplant. More now in patients who have greater than 10% plasma cells, we're using CyBorD in the United States, whereas BM-Dex is preferred in Europe as initial therapy. And with the initiation of induction therapy, patients are improving, and more patients are actually becoming transplant eligible. In high-risk patients with advanced disease, stage 3B, or New York Heart Association class 3 or 4, we have to be more gentle and not use combination therapy. So bortezomib, Dex, or low-dose combinations with intensive supportive care is the standard. For treating relapse disease, Ixazomib was the first drug to attempt to get FDA approval. Ixazomib is an oral proteasome inhibitor, much like bortezomib. It has less risk of neuropathy, has some side effects of GI toxicity, but it's very manageable. And so this phase 3 study was designed in patients with relapsed refractory amyloid to treat patients with Ixazomib and Dexamethasone versus physician's choice, because there was no standard of care. In this trial, physician's choice was either Cytoxan, melphalan, or lenalidomide in combination with dexamethasone. And the sad news about this trial is that it did not meet its primary endpoint, which was overall response rate. You can see here, this is the percentage of patients. This is the overall response rate, and Ixazomib was compared to the physician's choice arm, and these two numbers are very similar. However, we know that that's not the goal of therapy. The goal of the therapy is to have a very deep response, and the CR rate, the complete hematologic response, was better in the Ixazomib arm, and so was the duration of the hematologic response, which is quite important. We also found that there was a 90% reduction in the time to vital organ deterioration or death with Ixazomib and Dex versus physician choice, which is a meaningful endpoint. So the story doesn't rest on just the overall response rate, which was in the hands of the FDA, not enough to, because this drug didn't meet its primary endpoint of improved overall response rate. This drug was not FDA approved, but that is not the whole story, and this drug still has some meaningful benefits for patients. Carfilzomib is a second-generation proteasome inhibitor given IV, and maybe more potent than bortezomib because it's an irreversible proteasome inhibitor. This was studied in a multi-center trial and has an overall response rate of 58% in previously treated patients with a VGPR rate that was 45%, and so has meaningful activity. But this drug has some significant toxicity, especially cardiopulmonary toxicity, and should be used in caution with patients who have cardiac involvement. Bendamustine is in the class of drugs of the alkylators and has been studied in combination with dexamethasone. Also has a meaningful response rate of an overall response rate of 57% in patients with previously treated amyloidosis. But again, the toxicity is not trivial. It causes something called myelosuppression or low blood counts and often needs growth factor support. The immune modulating agents are widely used in patients with multiple myeloma and have been studied in patients with amyloidosis. These can be effective for patients, and here are 3 trials that I show you of lenalidomide and dexamethasone in patients with relapse disease, or the combination of Cytoxan, lenalidomide, and dexamethasone in patients with Upfront, treated Upfront with this combination, or pomalidomide and dexamethasone treated for patients with relapse disease. And again, these have a response rate and can result in treatment efficacy, but again, toxicity is not trivial, and these drugs can cause low blood pressure, low blood counts, cardiac arrhythmias, and fainting, and should be used with caution and at significantly reduced doses than what we use in patients with multiple myeloma because of the frailty of the amyloid population. The newest kid in the block are the antibodies, and I've been talking about anti-plasma cell therapy directly, which really targets the plasma cell in different ways, but the antibodies are actually bind to the outside of the plasma cell and stimulate your own immune system to clear the plasma cells. It's a more targeted approach, and the most commonly used and commonly known antibody is Daratumumab, directed against the CD38 molecule. Ixazomib is another anti-CD38 antibody that's being studied. CS1 is a molecule on the plasma cell membrane that can be targeted by the drug Ixazomib, which is being studied. And then I call your attention to these drugs, which are actually not directed at the plasma cell, but are directed at the amyloid fibrils or the protofibrils, the intermediates, which can actually help to clear the amyloid deposits themselves and result in improved organ function. So the first drugs that were studied were anti-SAP and NEOD-001, and unfortunately those trials have not gotten further because of either toxicity or no efficacy, but we're excited to say that 11-1F4 has some preliminary evidence of efficacy. It's now called KL101, and trials with this drug are ongoing. Lastly, I wanted to mention the BCMA, B-cell maturation antigen, is widely expressed on the plasma cell surface, and drugs targeting BCMA have been very effective in multiple myeloma and will start to be studied in amyloidosis, hopefully in the near future. So when we talk about the antibodies, again, Daratumumab is the most widely used anti-CD38 antibody in plasma cell disorders. And what was exciting that in the first publications using this drug in heavily pretreated relapsed AL, we saw an 80% overall response rate. And what was interesting was these were also very rapid, responses occurred very rapidly. So in the phase 2 setting, Vishali Sanchrawala reported that the hematologic response after one dose in 22 patients with AL amyloidosis was dramatic, and overall the drug resulted in a 90% overall response rate with 86% very good partial response in relapsed AL, which was unprecedented. And moving on to clinical trials, so this drug is now being studied in probably the most important clinical trial in AL amyloidosis. It's a randomized study of CyBorD plus minus with or without Daratumumab, and 360 patients or more have been enrolled on this trial, and we are eagerly awaiting the results because we think that this will be the first drug that's FDA approved. In preliminary report of Daratumumab plus CyBorD and the safety run-in of note, Daratumumab is given as a subcutaneous injection. The issue with Daratumumab has been that it's, to date, Daratumumab has been given as an intravenous infusion, which takes time, so and subcutaneous injection is more user-friendly. And amazingly, in the first 28 patients who were included in the safety run-in, the combination of Daratumumab and CyBorD resulted in a 97% overall response rate, with almost a 50% complete hematologic response, over 50% complete hematologic response rate, which is comparable to our data with transplant. Also several high numbers of organ responses. Other Daratumumab trials are in progress for both Upfront and Relapsed AL. The combination of Daratumumab, the oral proteasome inhibitor Ixazomib and Dexamethasone is being studied at MD Anderson. The combination of Daratumumab and the IMID, pomalidomide plus Dexamethasone, is being studied at Cornell, not yet recruiting, but soon to open, hopefully. And Daratumumab monotherapy in untreated stage 3B AL is being studied in Europe. Other antibody studies, lenalidomide, dexamethasone, and elotuzumab, the anti-CS1 antibody with or without cyclophosphamide, is being studied at 3 centers across the country, City of Hope, Carmanas, and in Denver. The antibody isatuximab, which has a little bit different properties, is again is directed against the CD38 molecule, but has some different properties than Daratumumab. Has been studied and is being studied in relapsed refractory AL across the country at all of the SWOG sites, and 39 patients have already been accrued, and we're awaiting the results of this study. CAL-101, which I'll talk a little bit more about, is the antifibrillar antibody, again directed at removing amyloid fibrils and in order to speed organ recovery. It's being studied with CyBorD in a dose escalation trial, and very excited to report the first 4 patients were treated, and so these studies are underway. I think Michael Spector is going to be speaking more about this molecule, but many studies hopefully will be forthcoming. Again, just to remind you that all of the treatments that to date that we have spoken about were directed against the plasma cells. CAL-101 is directed against the amyloid fibrils, similar to doxycycline is directed against amyloid fibrils. These drugs have to be used in combination with the anti-plasma cell therapies, because by themselves they don't turn off that factory that's producing these abnormal proteins. So other plasma cell directed therapy trials include of the class, the alkylators, the melphalan, which is an alkylating, novel class of alkylating agent, which is peptidase enhanced compound, which may have more potency. Captazole enabled melphalan, Evomela, is a novel formulation of melphalan being studied in transplant eligible patients, both in Boston Medical Center and at MSK. At MSK, we are using this drug. The formulation has a longer half-life, so we have developed a protocol where we can do PK-directed therapy, so we can treat patients, measure the dose, and really individualize treatment with this formulation. Other proteasome inhibitor trials include the all-oral regimen of Ixazomib, Cytoxan, and Dexamethasone, which are being studied in 3 centers in New York as upfront therapy. And in high-risk patients who have high-risk patients by virtue of having significant numbers of plasma cells in their bone marrow at diagnosis, are eligible for Ixazomib maintenance after initial therapy at MSK and Tufts. Just take a minute to talk about the novel agents where that trials that we're excited about. Venetoclax has unique potency in multiple myeloma. It's a BCL2 inhibitor. It has unique potency in multiple myeloma with a patients who have a particular cytogenetic abnormality, translocation 1114. And this cytogenetic abnormality is seen in about 50% of AL patients, even more in AL than in patients with multiple myeloma. So initial trial of relapsed refractory amyloid is was opened at Boston University. There was some indication of toxicity with this agent, mostly infectious toxicity, and so that's on hold, but we think that that additional trials, especially in AL with this translocation 1114, where the efficacy has been seen, are planned and will move forward. Again, anti-fibrillar agents have to be used with anti-plasma cell therapy. Doxycycline, which is an antibiotic, interferes with fibril formation and abrogates light chain toxicity. There are some data for this, retrospective data, showing that this can be helpful in AL amyloidosis, and a randomized trial versus best supportive care is ongoing in Europe and Canada. KAL-101, again, the anti-fibrillar antibody plus the novel anti-CD38 antibody would represent dual monoclonal antibody and get rid of all of the chemotherapy agents which have more toxicity, is planned moving forward. And I would say that we can stay tuned for BCMA-directed therapies, which again have been very effective in multiple this BCMA targeting has been very effective in multiple myeloma, and we are hopeful that we will see similar activity in patients with AL amyloidosis. I just want to say that I hope that reviewing all of the trials and reviewing all of the agents gives you hope, because we have many more options than we did even when I started treating patients. And I'm hopeful that we will finally have at least one FDA-approved drug for this condition. But I do urge you to, I can say that the NCCN guidelines, the national guidelines, are really that all treatment for AL should be in the context of a clinical trial, because that's the only way that we're going to get these drugs approved. Understanding that clinical trials aren't available to every patient, but if they are, I would urge all patients to participate. I'm just going to take one moment to discuss treatment of AL in the setting of COVID-19, which is our public health crisis, and the reason why we're doing this as a webinar instead of in person. So patients with AL in this public health crisis should really be considered at risk of complications and mortality from the coronavirus infection, especially patients with heart involvement, who are independently associated with a higher risk of mortality. And then add on top of that, the drug that is being widely used to treat COVID-19, again, with very little data, can cause particular cardiac toxicity, which would be, could be detrimental for our patient population. Also, patients who are on the treatments that we just discussed, these immunosuppressive therapies, may be more at risk of getting the virus. Although there's not much data at all in regard to this, as we're using sometimes in the setting of the virus, we're using immunosuppressive therapies for treatment. But what should we do? Should we alter therapy? The ISA, the International Society of Amyloidosis, has put out some recommendations, and really they're guided by social distancing and stay-at-home efforts, which I would urge is really, really the most important thing. What we're doing at our center is delaying elective transplants, which I would say that is happening across the country. If possible, relying on oral combinations rather than IV in order to reduce the risk of coming to the center, similarly decreasing the frequency of IV administration in patients who have disease that is really responding to their therapy and have where treatment can be liberalized. But again, most importantly, stay at home, social distance, and stay safe.
I know you're very scared, but it's okay. All you need to do is drink water and lay in bed and take a long nap or something, and use tissues and eat healthy food like probably chicken nuggets, all that healthy stuff. And I know you're scared, but just calm down. Take a deep breath, 2 deep breaths, and count to 3. Take 3 deep breaths.
So I just want to thank you so much for having me today. I really think that putting this together, I hope that I thank Muriel for putting this together, and I hope that seeing all of the available therapies, although not FDA approved, but potentially available therapies, give you hope for treatment of amyloidosis moving forward.
Thank you so much, Dr. Landau. That was really wonderful, especially that strong piece of advice from the littlest member of the family, I would assume, right? We're so grateful that you could join us today. I do want to mention there's no need to call your ophthalmologist or optometrist if you don't get your glasses adjusted. And we have blur-free slides to share with you. We have a meeting link to share as well. So